Welcome to the GP Pharmacy Club Pod. Today we discuss the updated NICE Guideline NG217, which focuses on diagnosing, managing, and treating epilepsy in children, young people, and adults. This guideline was released on January 30th, 2025, and aims to improve diagnosis, enhance treatment for different seizure types and epilepsy syndromes, and reduce risks for people with epilepsy. Let's start off with a quick overview of NICE Guideline NG217. This NICE guideline provides a structured approach to diagnosing, managing, and treating epilepsy in primary, secondary, and tertiary care. The goal is to improve diagnosis, enhance treatment for different seizure types and epilepsy syndromes, and reduce risks for people with epilepsy. It starts off with diagnosis and management in primary and secondary care. In terms of referral and initial assessment, urgent referral within 2 weeks is recommended for children, young people, and adults after a first suspected seizure. Diagnosis should include detailed history taking, including eyewitness accounts and video evidence, electroencephalography, EEG, to support but not exclude epilepsy, neuroimaging. MRI is preferred, to identify structural causes, and genetic testing in cases of early-onset epilepsy or suspected genetic syndromes. There are some key treatment principles to consider. Anti-seizure medications, ASMs, should be chosen based on seizure type and epilepsy syndrome. Medication withdrawal can be considered after 2 seizure-free years. Drug-resistant epilepsy should be evaluated for ketogenic diet, surgery, or vagus nerve stimulation (VNS). Referral to tertiary services is recommended when diagnosis remains uncertain, seizures remain drug-resistant despite first- and second-line treatments, specialized interventions are needed, or participation in clinical trials is possible. The guideline then looks at types of epilepsy and their treatment options. Generalized epilepsies involve seizures that begin in both hemispheres of the brain simultaneously. Treatment options for different types of generalized seizures vary depending on the type. For generalized tonic-clonic seizures, GTCS, the first-line treatment is sodium valproate, which should be avoided in females of childbearing age unless necessary. Alternatives include lamotrigine and levetiracetam. Second-line options are perampanel and topiramate. For absent seizures, first-line treatments are ethosuximide and sodium valproate. Alternatives include lamotrigine and levetiracetam. Avoid carbamazepine, gabapentin, oxcarbazepine, phenytoin, and vigabatrin as they can worsen absent seizures. For myoclonic seizures, juvenile myoclonic epilepsy, first-line treatments are levetiracetam and sodium valproate. Second-line options include brivaracetam, clobazam, clonazepam, and lamotrigine. Avoid carbamazepine, oxcarbazepine, gabapentin, and phenytoin. For tonic or atonic seizures, Lennox-Gastaut syndrome, the first-line treatment is sodium valproate. Second-line options include lamotrigine, topiramate, and rufinamide. Third-line options are cannabidiol, ketogenic diet, vagus nerve stimulation, and surgery. We now move on to focal or partial epilepsies. Focal epilepsies involve seizures that originate in one hemisphere of the brain. First-line treatments are carbamazepine, lamotrigine, levetiracetam, and oxcarbazepine. Second-line options include brivaracetam, cenobamate, eslicarbazepine, and perampanel. Third-line options are phenobarbital, phenytoin, and sodium valproate. When it comes to childhood-onset epilepsy syndromes, treatment options also vary. For Dravet syndrome, first-line treatments are sodium valproate and stiripentol with clobazam. Second-line options include topiramate, cannabidiol, and ketogenic diet. Avoid carbamazepine, lamotrigine, and phenytoin as they worsen seizures. For infantile spasms, West syndrome, first-line treatments are prednisolone, tetracycline, and vigabatrin. Second-line options include ketogenic diet, cannabidiol, and surgery if a focal lesion is present. For self-limited epilepsy with centrotemporal spikes, Rolandic epilepsy, first-line treatments are carbamazepine and oxcarbazepine. Second-line options include zonisamide and sulthiam. Finally, for epilepsy with myoclonic atonic seizures, DU syndrome, the first-line treatment is sodium valproate. Second-line options include lamotrigine, topiramate, and ketogenic diet. The guidance also looks at reducing risks for people with epilepsy. In relation to preventing epilepsy-related deaths, including SUDEP, strategies for preventing epilepsy-related deaths include identifying high-risk individuals, such as those with uncontrolled seizures, sleeping alone, non-adherence to medication, encouraging adherence to medication, and considering nighttime supervision. Ensuring smooth transitions from pediatric to adult epilepsy services is crucial for continuous care. The guideline also addresses psychological and cognitive support. Addressing mental health comorbidities, such as depression, anxiety, and ADHD, and providing epilepsy specialist nurses for continuous care are essential components of comprehensive epilepsy management. There are non-pharmacological treatments for drug-resistant epilepsy. These include the ketogenic diet, epilepsy surgery, and vagus nerve stimulation (VNS). These treatments have shown effectiveness in conditions such as Dravet syndrome, Lennox-Gastaut syndrome, and Deuce syndrome. In conclusion, the updated NICE Guideline NG217 ensures personalized, evidence-based treatment for all seizure types. Early referral to specialists and access to modern treatments improve outcomes. Avoiding medications that exacerbate seizures enhances patient safety, and integrating non-drug therapies provides options for drug-resistant cases. Thanks for listening to this episode of the GP Pharmacy Club Pod. Join us again next time.